want to go to the restaurant and avoiding any loss of overdenture, right? And this happened to a lot of old people. But at the same moment, they can't afford a hole-on-6 or a full restoration, fixed restoration. So very often it happens to me to place 2 implants in the mandible, working on bone expansion and with 2 locators. This is my choice. I work a lot and a long time with O-rings, but I think that's even with its limitation, but locators are superior. But the good thing is that in the maxillary arch, we're actually the internal consensus, even for overdenture supported by implants, the consensus is the placement of 4. But in my opinion, placing 4 implants just to support an overdenture doesn't make any sense, because you just have or need to place 2 more, and at least you have hole-on-6. I'm not a strong believer, even I've been doing this, of hole-on-4. So I rather prefer hole-on-6. But you know, this is my choice. Either 2, and because I'm working on bone expansion and shifting the bone density, I'm able to place 2. I have a very nice case here, ensuring that you can place where? Your 2 implants in the canine pillars. We know that the canine pillars are the strongest part of the face. And at the same moment, that means that in almost all the cases, you can place an implant there. But if you undersize your bone bed preparation, that means you're undersizing it. It's easier, because the problem, where is the main problem? Is going either towards the sinus or in the nasal cavities. But if you're working in bone expansion, in most of my cases, I have a lot because I'm doing this for a long time, and working with your osteoderms, then you will expand the bone, and you will bounce from a cortical to another one without avoiding any lesion of your either sinus cavity or nasal cavities. And because I'm expanding, so it's a hard structure. I never lost an implant supporting an overdenture, even in the maxilla.
There was a question.
Thank you very
Can
much.
you get it?
Thank you very much.
You're welcome.
I just asked a question about when I want to do a bone expansion technique for thin ridge.
Can you speak up or come closer? Or can you ask? Please come.
Thank you very much for your valuable presentation. I want to ask a little question about when I want to do a bone expansion technique for thin ridge. What about the biologic bone reaction against these techniques? Is it liable to occur acute inflammatory reaction as a result of this expansion or no?
No, actually not. This is a very good question. The question was this: in using this bone expansion technique, will I face or shall I face any inflammation in the tissue? Right? I tell you, in my experience, because I'm using daily bone expansion and working only on bone expansion, and actually I'm working with some prototypes devices from Anthogyr to apply a higher torque. But the thing is that you have to understand exactly what you're doing. And this is why, if you remember well, I place you these slides and showing what you can do if you expand the bone. The major issue in expanding the bone, I should say, it's not getting stuck by the fact that your bone expansion is too high. That means I'm just explaining this. If you use a drill and you undersize because you want to expand your bone, then you will end up, if you're not taking care of this, you will end up by leaving bone debris. Then, if you expand this bone by the use of either osteotomes, manually or with an electrical mallet that we are developing and that Anthogyr will put on the market in the next months, I think.
Next trimester.
Next?
Trimester?
Yeah. Or you're using any bone expanders, rotary. That means that you will condense the bone. And remember this comparison that I gave in utilizing the rotary instruments in Ando. That means that you will condense your bone naturally in your bone bed preparation. And this is critical. This is critical because what is the main issue of this? Is keeping your blood supply. In any cases, when you're working on implantology, you have always to think about your blood supply. This is the main question. This is the first question that have to come to your mind. So at the first step, in making a flap or not, in drilling or using some different devices like piezo or rotary instruments. But that means that, and I will give you my trick. If I'm using even in a D1, dense bone, I mean, D1 in Lacan and Sgar classification is the denser bone. Well, first of all, we passed the problem of the cortical layer, but then we have a dense bone. That means that very often in dense bone, the blood supply is not that rich, like a D3 or a D4. You face that, right? That means that if you're not taking care of your compression, then you will end up by a socket completely dry. And we know that this could be a problem. So my trick is there. Even I'm using rotary instruments, then I will try to clean out the preparation of my bed implant. That means, in my case, and I'm sure that they will invite me to show you all this about the use of lasers. But in my case, I'm using the laser, a cool laser. I mean an erbium laser, and be advised of this because some of you asked me this. If I'm using a laser like a diode in the bed preparation, you will end up by a necrosis. This is for sure, because you have an heating effect. That means that in my case, I'm using this erbium laser just to vaporize these bone debris. And some, I remember, because that was a main concern. Because some implantologists, they told me, oh doctor, but what about the problem of having these bone debris? Because when we are grafting, we're grafting these bone debris. Not really. This is not true. And this is actually one of the main problems you're facing, where, for example, you're making a grafting procedure, lateral axis of the sinus. If the volume is too important, if your packing is too strong, what happens? Necrosis. Because what?
No blood.
No blood supply. No neoangenesis in the middle. So you see, all these steps have a reason to be. And to get back to your question, in these cases, I will try to clean out this socket and just working on bone expansion by the strength of the implant itself. And this is why the titanium grade of the implant is very important. It's critical, actually.
How often you do expansions in the lower one, right?
Yeah.
I do them only in the upper. I never tried the lower.
This is a good question. Why?